And I think most importantly, when we look across the world, governments are taking measures and advising their citizens on practical measures to take to ensure that the spread is curtailed. So what we're discussing this afternoon is what is Nigeria's response to that? And we have an exciting panel put together, and we wanted to really get a good experience from the beginning of the pandemic to where we are now. The beginning of the pandemic in Nigeria was very much one person bringing it in. And the very first state it went to was Ogun State. And this is why we thought it was right to have a representative of that state to speak to us this afternoon. And unfortunately for us, but we're still going to have a great time, unfortunately for us, she is bereaved and had to go away. You will be pleased to know that her bereavement is not due to COVID-19. It's something else, but it's a close relation. So our thoughts are with her. She's unable to join us this afternoon. So we do hope that she can join another series in future. We also had another representative from Cross River State, where they have 0 COVID-19 cases. And we were really looking forward to that, and we are still looking forward to that, for Mr. Ekpeyong to join us. He's the Commissioner for Finance, and he would have been wearing the hat of health as well as financing some of these health policies and what it means for states. So he is presently being called away. He's the secretary to the COVID-19 response team in Cross River, and he's been called away, and but he hopes to join us. So as I speak, he's airborne, and hopefully, if he gets to his destination in time, he's going to join us just after 4:30. So we're really looking forward to that, and we hope that he's able to join us. Thirdly, for us, probably our most knowledgeable and exciting speaker, for me anyway, this afternoon, I'm going to refer to him as Dr. K, because I've told him, I've taken lessons in pronouncing his surname and been unsuccessful. So I'm not going to insult his intelligence, I'm not going to insult his personality by trying to pronounce his surname. But it's Dr. Kayode that his first name is, but I'll let him introduce his first name. He wears several hats today, and he's really going to break down what COVID-19 really means for all of us in terms of when it came to Nigeria, what were some of the steps that NCDC took. His role with NCDC is a consultant with a medical background, an independent consultant who is well versed in the area of human capital development, is quite versed with working with governments and donor agencies, and he's been involved with the implementation of innovative, human-centered designs, approaches to saving lives. You'll also be pleased to know that he hasn't only worked in Nigeria, he's worked with other African countries, such as Kenya, Rwanda, and the Gambia, and so on and so forth. But you'll be also pleased to know that he's homegrown. He's schooled in University of Ibadan and did complete some international studies in Cardiff in the United Kingdom. But this afternoon to us, he's going to be answering questions such as NCDC's immediate response. Where did it all start from? While it was going on, what are some of the measures they decided to take? What are the challenges they faced? How much reaction did they get from the public? How were they able to deal with it? Where we are now and where we hope to be. So that is our program for today, and a brief introduction of all our panelists. As for you, our audience, we welcome you. We're thrilled that you've taken the time to join us for this. We know you could be spending your Saturday in a different place, but you've chosen to be with us today. So we are grateful. What we ask at this time is to minimize the distraction. If we can respectfully ask you to switch your cameras off, because that also helps with the productive, with the productivity and the quality we get from Zoom. So if I can ask that as the audience, we kindly switch our cameras off, that would be really good. If you're not able to, it's not a problem. We would love you to interact with us. We cannot complete this program unless you interact with us. So please type your questions into the chat box, which I will be checking and making sure I bring to the attention of our speakers. So without further ado, as you can see on your screen, is the short profile of Dr. Kayode, and it covers some of the things that I've mentioned, but I would now like to ask you to give him a warm Zoom welcome as Dr. Kayode takes over to address us this afternoon. Thank you, Dr. K. Over to you.
Thank you very much, Beam. Thank you for having me. It's a pleasure to be here. I'm also looking forward to the interesting discussion on COVID. I'm sure you all agree that these are interesting times. One of the ways we're trying to keep abreast or stay ahead of the curve while we try to flatten the curve through mediums like this, where we share information, update our knowledge, and we kept abreast of what is going on, especially within Nigeria, but also by extension, what is going on globally, because it's a pandemic. So there's, as far as possible, as of the last count, over 200 countries have reported at least a case, and that is still growing in different countries. Seems the epidemic is shifting across regions and territories. So happy to join everyone here today. Thanks for not murdering my name, Bim. Dr. Well, that's fine. Dr. Kayode is okay. Kayode also great as well. So we'll be working with the NCDC over the last couple of months, trying to shape the strategic direction for the response as much as possible. It's been a tough one because we're in a very interesting situation given the novelty of the virus. I mean, this is not malaria that we're all used to, or even Lassa fever, which some extent was discovered in Nigeria, and we seem to know what drives it. This is very new, it is imported, and we're still learning, frankly. There's a lot of publications on a daily basis that keeps getting churned out, just so that we have better understanding of this. And the more understanding that we have, the better we are to respond collectively across board. So happy to be here and look forward to the discussion today. I believe over to you, Bim, to run this through. Your mic is on mute. You're on mute.
Yes, thank you. Thank you for that introduction. I guess where we would like to start from this afternoon is really to say, when we look back at the beginning of the year, nobody had heard of any virus. Perhaps we heard bits of it coming out of China, but I think like every other person in the world, no one thought it will reach the end of the earth and back. And so where we want to start from is the beginning. At what point did NCDC get wind of this? And, was it when it was declared a pandemic? What was the genesis? What was it like? When was the first time we actually heard of it in Nigeria? And when was the first time you as an independent consultant got called for help by NCDC?
Great. Thank you very much, Bim, for that interesting question. I mean, for us, we need to understand the beginning so we get the sense of where we are and where we intend to go to. As everyone in the world, I mean, bad news travels fast, and infectious disease is one of those things that basically spreads quickly. Again, if you cast your mind back to the Ebola outbreak in West Africa, news was all over everywhere before it got to Nigeria. Also with the SARS outbreak in China in 2003. So for this was very similar, and news started filtering through verified sources. There are a couple of sources that comb for infectious disease outbreak alerts globally. So a couple of us belong to this platform, and this has been sieving through those platforms as far back as December. Mid-December, some cases, but it got heightened towards the end of the year in 2019, December 2019. Of course, until the WHO declared this an ongoing epidemic, and then subsequently a pandemic. So you've seen how this has evolved across countries. Interestingly, for China also, with the news was that it was at a particular, it was an interesting point in the calendar year for the country. The traditional, I think it's called the Moon Festival, where there's a lot of travel in country. So that basically fueled a lot of speculation, as well as for the news about the possible potential transmission of the illness at that stage, where there was minimal knowledge of what was even going on. Of course, what was happening was just a constellation of cases, similar cases, fever, cough, some sore throats, which were becoming quite rampant and popular at the time. Of course, their surveillance system was able to pick it quickly, and that alerted a couple of other countries. Bringing that home to Nigeria, of course, given that Nigeria also has access to a couple of these information sources, the country was well aware. So let me take it to Africa first. Africa was definitely aware. And through Africa, I mean the African CDC, which is the health arm of the African Union, basically ensuring that they galvanize a lot of support to protect Africans on the home soil. Given the trade relationship between China and a lot of African countries, that initial risk assessment was done to identify the hotspots for how the disease could spread. Of course, you agree with me because of airlines, the air travel. It only takes a couple of hours for illnesses to spread. Again, quickly leveraging what happened with Ebola, where we had a case traveling from Liberia. Also, the same thing happened, both at the continental, thinking about a continental strategy. Say, okay, where are the hotspots? Of course, Nigeria within the West African region was one of those, but also Ethiopia, South Africa, given the travel route and the traffic between China and Africa. What the African Union, African CDC did with that was basically prioritize and what's the only way you can know you have an illness or you have something ongoing with you is to be able to test. So you need to have sufficient laboratory capacity. That at the time, as far back as January, was very, very weak. Very few African countries even had the capacity to test. So that was one major strategy at the African level that the continent pushed forward. I stand to be corrected, but I actually think we did have, as a continent, some capacity before the US, to be able to test and diagnose this. Of course, there are other equipment available, but so strategically, the lab framework was quickly strengthened. There's a lot of capacity building initiatives done, led by the African CDC, initially face-to-face, but as the disease began to spread, this became very remote. So using platforms such as Zoom or other teleconferencing mechanisms to quickly increase capacity in infection prevention and control, but also increasing laboratory capacity. But very importantly, increasing surveillance across points of entry, so a lot of airports and ground crossings. For Nigeria, as far back as January, the National Emergency Operations Center had been activated. The Emergency Operations Center was in 3 levels. It's at 3 levels. Actually, there are 3 levels, from level 1 to level 3, 3 being the highest. That graduated gradually, or that increased the level of activation increased gradually as the disease progressed. So as of January, we're at between level 1 and 2, setting up systems, building capacities, working with state governments, doing trainings, conducted a couple of simulation exercises to ensure that we understood what we were, try to understand what we were going to face. Given that the virus was novel, for a lot of the simulation exercises, there's only a limit to what you might be able to prepare for. And that's, again, something that has been recurring across countries during this outbreak so far. So that was basically what Nigeria did in building the capacities. Of course, quickly strengthening the laboratory testing network. I had mentioned that the African Union was very supportive in providing the first tranche of commodities. A lot of other contributions followed, which was very popular and common in the news. So there's a lot of structure around coordination, capacity building, setting up surveillance structures. So at the point of entry, and as well as communication, which is very important. I will come back to communication as we go along this, because it's really a very key component of this response, given the infodemic that is quite prevalent for this so far. So a couple of the states were able to develop what we call incident action plans, IAPs.
Right. Sorry to interrupt you there. Let me just ask you to take a break there, because I'm glad you touched on states. And we have our Ogun State representative with us. I think it's going to be for a short period, because although she has a family commitment, she has still been able to join us. So what I want to do is, now that you've mentioned state, I'd like to bring her in, because Ogun State remains the ones that had the first visit of COVID-19. And for us, we want to understand how they were able to deal with it. How did they find out? What was their reaction? And I know that time is not on our side, so we're so grateful. So permit me to just bring her in for a few minutes, and then we're going to come back to you in terms of the state capacity. Thank you so much for opening up nicely and giving us a really good background on where COVID-19 started from. It is my pleasure to welcome Dr. Tomi Coker. We are so grateful, Honorable Commissioner for Health in Ogun State. You've joined us this afternoon, even though you have a family emergency. We're really grateful you're able to do that. Just some information about Dr. Coker. She is the Honorable Commissioner of Health in Ogun State, and she has been leading the state's innovative response to COVID-19. She is a medical doctor who obtained her degree from University of Ibadan, similarly to Dr. K, funny enough, who is also from University of Ibadan. And she has a keen interest in clinical governance and a passion for promoting female well-being. She's held several roles, such as being the vice chair of the Royal College of Obstetrics and Gynecology in Nigeria liaison group, and she collaborates with local professional bodies in advocacy and promotion of women's health in developing countries with a focus on Africa. Of course, she's a fellow of our profession, an alumnus of leadership training in healthcare management at Harvard Business School. And as I said this afternoon, she's just going to be speaking to us about when did Ogun State get their first patient or victim, or whatever I can call whoever's been infected. How did they know? What did they have in place? How did they deal with it? How did they manage the situation generally? And what can they pass on to the rest of us? So ladies and gentlemen, please join me and welcome Dr. Tomi Coker as she addresses us for a few minutes. You are welcome, Honorable Commissioner. Thank you, Ma. Thank you for joining us.
Thank you very much for inviting me to the Zoom meeting. Well, I'll just start from Ogun State, being the first state to register the index case, which was on the 27th of February. And since then, we have been responding to the COVID-19 as well as preparing. A lot of the other states had the opportunity to prepare, but because we had the index case both in Nigeria and Sub-Saharan Africa, we had to, go into the response immediately. But whilst doing that, we set up our Emergency Operations Center, which my colleague alluded to earlier on, and then we had 6 pillars, which were in charge of sort of risk communication, logistics, case management, and the coordination of the response, surveillance, more importantly, and infection prevention and control. And through those pillars, we were able to then focus, each pillar focused on those aspects. But for Ogun State, the case management team established 5 isolation centers, because if you remember at the time where we had the first case, we actually weren't aware of the number of ICU beds we had. We did not have any isolation centers in operation at all. So within 4 weeks, we had to set up 300 isolation beds, and we also acquired 24 ventilators, and also we went ahead and acquired ambulances, because that was a key thing that we realized that was required in transporting the patients, because a lot of the patients initially were at home and the state had to go into their homes to test them. And after testing them, when they tested positive, we conveyed them to the isolation center. It was the response was very, very centralized. However, we realized that could not work. So today would be our 118th day of response. And since then, we realized that our healthcare systems would really get overwhelmed if we continued centralizing the care. So we've decentralized in our sampling of the patients. And in doing so, we've also used technology to support us. We've used technology to reach out to our healthcare workers to train them in infection prevention and control. So they have a web-based test that does a pre-test, educate them and do a post-test, and they get certified. So to confirm that they actually know what to do when they're confronted with a patient that is suspicious, that is suspected of having COVID-19. This is one, to ensure that the patients do get the right care and they're categorized appropriately, and that other non-COVID diseases are not neglected. And two, it's to actually ensure that our healthcare workers are not exposing themselves unduly to the hazard of COVID-19. So by ensuring that nobody that gets below 75% is certified to be trained in infection prevention and control, we're able to reassure ourselves that healthcare workers are well looked after. Talking about healthcare workers, we also got life insurance for them, to make sure that should any one of them actually get infected with COVID-19, and if there is ability, can you hear me? And if if there is a fatality, that the individual's family are not left wanting, especially with
Okay, so it seems to be breaking off a bit. Right, okay. So what we're going to do is, while it sounds like she's on the move, so it's probably cutting out depending on where she is. So apologies for that. Dr. K, if I can bring you in, it's interesting that Dr. Coker mentions quite a few measures that they've put in place, and I have to say, rather impressive. Can you hear us again? Are you back with us?
I can now.
Okay, all right. I'm going to come back to that question, Dr. K. Carry on, Dr. Coker. Thank you.
So with the healthcare workers, we've been able to actually get insurance, life insurance, so that their families are not left wanting should there be any fatalities. But I must say at this point that Ogun State has one of the lowest infection rate in health workers, being that we're ranging at about 0.6%, which is way below what other states and countries are reporting. This might be as a result of another technology which we introduced during our sampling, which is the mobile, walk-in sampling booth, which encases the healthcare worker, protecting them from the potential patient. So when the swab is being taken, the worker is protected by a Perplex screen. And also the advantage of the booth also is that we actually were able to save financially the number of PPEs that the health worker actually consumed during the exercise. The combination of this probably led to our low rates of infection, because the aerosol is spread when people open their mouth wide. That's the highest risk of health worker getting infected when samples are being taken. But we can proudly say that very few of our healthcare workers have had to be exposed unduly.
Wow.
Where are we now? As far as testing is concerned, we have two molecular laboratories in the state. We have 3 senatorial districts, and we have 2 molecular laboratories in the Ogun Central and Ogun East. And we're fortunate enough to actually be acquiring a 3rd molecular, PCR machine in the Ogun West, which is the 3rd senatorial district, on Monday. That means our testing capacity is over 1,000. However, the challenge is that individuals are not presenting themselves for, sampling because of the unfortunate stigmatization of individuals that have tested positive. In the initial phase, people who tested positive had their homes attacked. Hospitals that diagnosed patients had their hospital threats of arson on their hospitals. But with increased communication and sensitization of the population, I think people are now aware that, there's no need to stigmatize, and the fatality rate is sort of 2% in Nigeria. They're about 2.4% in Nigeria as a whole and in Ogun State, which is, I think people are a little bit more relaxed, because initially what people were seeing on the screen in Europe and in America were fatalities, the extreme cases. When we've looked at the case, the pattern of disease in Nigeria, 97% for us in Ogun State are asymptomatic to mild. And then we have, as I said, about a 2% mortality rate. And very few in Ogun State. We probably had 2 out of the 790 cases we've diagnosed. We've only had 2 critically ill patients that required ventilation. But that doesn't mean it's the same for other states. So since we realized that 97% of our patients are actually asymptomatic to mild, we've now moved into the home management. That's part of the decentralization, where once the individual is identified and tested and is positive, our surveillance team, which is one of the pillars that we have, move in to that community. They start the contact tracing and also the education of that individual and their family. And we then also prescribe them their drugs so they can actually use their drugs at home. This, as in our observation, reduced the incidence of stigmatization in the community. And going forward, I think Nigerians they're getting used to the fact that COVID-19 is still going to be with us for a little while. But the challenge as a government that we're having is the non-compliance of individuals with a directive of wearing face masks, social distancing, and also washing their hands frequently. The only way we can actually defeat this virus in our community is by adhering to this directive. And what does the future hold? The future is that COVID-19 is going to be around for a little while longer. From our SRI model, for us in Ogun State, if our R value is 1.5, we'll be peaking in September. If our R value is 0.6, like it was earlier, we'll be peaking in February next year. What does that tell us? That we actually do not know, because this is a novel virus. We just have to try our best to adhere to the directive, so that one thing, is that we know is the virus can only replicate if it has human vectors. And how can we stop the virus from replicating? By wearing our masks, distancing ourselves, washing our hands, so that after a while our R value actually falls way below 1, and within a short time, we will be able to actually eradicate the virus, or at least completely contain it in our society. It might not go away completely. It might end up being like the flu virus, that we would still have a few people having it, but it would not be a pandemic or an endemic as we have it as now. So
Okay.
thank you very much. That's
Thank you so much. Yes.
because of the topic, you talked about the lockdown and the businesses, people returning to work. So Ogun State was locked down for about 2 months, but we've reversed the lockdown. And in reversing the lockdown, what we've done is actually issued an infection prevention and control guideline to our workplaces to help them safely return their staff to work, and also to ensure that productivity and productivity and the economic situation of the state is revived, because the fallout of COVID-19 is food insecurity, financial insecurity. There is physical, challenges with physical security, and also your biosecurity as well. So to return the economy of the state to start to revive it again, we had to encourage industry, factories to go back to work, and for farmers to start farming, so that the people, rather than being malnourished and without, being stricken with poverty, can start to earn their living, because over 70% of the citizens of Ogun State earn their living on a day-to-day basis. And so reviving the economy is boosting their ability to actually buy food that would keep them healthy and ensure that they don't succumb to the virus should they actually get exposed to it. So that is where we are in Ogun State, and we continue to respond, and we continue to contain and curtail COVID-19 in our midst.
Wow, very, very impressive. Thank you so much. Are we sure Ogun State is in Nigeria? It's amazing. So all the measures that you've taken pre and post. But one of the questions I wanted to ask as well is that we know your index case was a foreigner. It was an Italian. How did you manage that? The Italian authorities get involved? It is, employers get involved. How were you able to manage that safely? Get him, to recovery and then fly out again? How did that pan out? And in terms of those you came in contact with as well, how did all of that work out initially? Because that was still early days.
Sorry, I can't hear you.
Okay, so I was asking, can you hear me now? Can you hear me? Okay, so I think there might be an issue with transmission again. We'll probably type that question, and we've got a question for her as well. So let's go over to, can you hear me now?
I can.
Okay, lovely. I'm going to ask you this question actually, which has come up. Experience has shown that Ogun State looks to be the first in everything political, and others, most of the carriers are asymptomatic, as you said. I'm suggesting that we should also liaise our solution and Ogun State take the lead, which is one of the questions I was going to ask you. How is Ogun State sharing this success? Are other states coming to you, or are you having to proactively share with other states some of these success measures?
We've had some of my colleagues, commissioner colleagues, that have contacted us to ask what our response was like, and some of them have implemented the things that we have implemented. But more importantly, we have a commissioners forum, Commissioner for Health forum, and we have governors forums as well that happen regularly. And recently we've had the National Health Council meeting, where all the commissioners from the 36 states and the FCT, with the Minister for Health and the Federal Ministry of Health, we had a meeting, so we were able to share our experiences, our challenges, and we learn from each other. No one has the full answer. We're just learning from each other. Some things will work for me and some things will work better in other states, but we are definitely communicating and sharing with other states.
Fantastic. And how about the discovery of medication? What is that looking for in Ogun State? And where do you think, what part do you think you'll be playing in finding a vaccine, a solution? Because we talk about the virus being around for a long time, but what's going to happen? Are our eyes on any medication that have been discovered around the world? You know.
Well, to develop a medication or discover a medication involves investing a large sum of money. A state like Ogun State, our IGR could not support that. But what we've done is we've actually aligned ourselves with the WHO Solidarity Trial to discover the new vaccine. And that way we're contributing our own quota to the discovery of a new vaccine. If the vaccine does come and we're able to try it, I would encourage Nigerians to actually avail themselves, because it's not about self, it's for the good of all. And until we test the vaccines and ensure that it's, it is effective in human beings, we cannot start giving it to a larger populace. No drug, no vaccine is ever developed without having to try it in a group of people with their consent. The vital thing is every individual that is involved in the trial must.
Okay, I think we have a freeze there. I think she was going to say they must have their consent before the trial can take place. All right, okay. So I think if we have any questions for Dr. Coker, can we please type them in? Yes, we've got you back. If we have any questions for Dr. Coker, can we quickly type them in just so that she can take any questions you may have, because she's with us for a very, very limited time.
Hello.
And I do need to, hello?
Hello? Can you hear me still?
Can you hear us? Yeah, we can, but it still keeps cutting out.
I think I have to go now. If you can hear me, I'll have to go.
Now, yeah. I think you ended up saying that whatever happens, the test must be with consent.
Sorry, I've got to leave.
Right, so the okay, I'm gonna bring in I'm gonna bring up Dr. K and continue on the NC. Dr. K gave us from Dr. Coker what Ogun State has done. What we want to know is how much has okay. Right. How much influence, Dr. Everybody's back, right? Okay. So how much influence has NDC had on schools, would you say, in your opinion, Dr. K?
Sorry, I didn't get that question. How much?
The question is, we just heard from Dr. Coker on the state level, some of the things they have in place, how they were prepared for the pandemic. How much of that is driven by NCDC? What is the interference level? How does NCDC work with such states to make sure good practices are shared, or even to proactively lead states to good practices?
Yeah, thank you very much. Great question. So the NCDC is the national body with the mandate to protect the health of Nigerians. I'll give a bit of a context. So within all the response work is embedded within what we call a health security framework. And this is driven by international agreements and laws. One key one is international health regulations. Within that, the NCDC is the IHR national focal point, given with the mandate to ensure that coordinates this sort of activities in country. Because Nigeria is a federating system, you've got the federal, you've got the state, you've got the LGA, with some bit of autonomy across levels. But what the NCDC does as a national body, as a national front-facing agency for this, is set the guidelines and set the standards. A lot of the things the Honorable Commissioner mentioned earlier were very true. A lot of these were concerted efforts between the national as well as the state. One of the critical things NCDC did at inception was support all the states, interestingly, Ogun State, with what we call rapid response teams, sort of boots on ground. These were field epidemiologists trained and sort of staff of NCDC who are deployed to the field to increase contact tracing, support contact tracing, support the establishment of the pillars that she mentioned, and also work with the state to quickly get on top of the response. I mean, for her, unluckily, I have to say for Ogun, they didn't go through the phase because they were just still hearing about it in the news, and next thing there was a confirmed case. So there was no graduation from preparedness mode, trying to put this in place. They went into it head on. So it's not, you can't do it alone, especially when you have one of your own as a federating entity being hit. Everybody needs to put their hands on deck to get that done. And NCDC was very proactive in that. There's a lot of supplies that came in, so a lot of PPEs, a lot of commodities, a lot of lab reagents. I talked about the laboratory equipment. There's a lot of push right now on the laboratory side to increase the laboratory training capacity. When the outbreak started in Nigeria, as of February 2020, there were only about 5 labs, or even probably less, capable of testing. These were a lot of labs that were currently being used for the Lassa fever outbreak. Again, it's using the same technology, the PCR molecular diagnostic capacity. Don't misquote me. The ability to test is, you need to strike a balance between safety, and so it's not a roadside lab that you can walk into. So at least you need to have a BSL2, so biosafety security lab level 2, for you to be able to test for coronavirus. Given, so meaning you need to have the equipment, you need to have the human resource, you need to have the equipment, the resource, the reagent, and all that to be able to carry this out effectively without jeopardizing or risking the health of people working in that lab. But what had happened over the last couple of months is, as of 2-3 days ago, there are about 39 labs right now. There's a lot more engagement with the private sector. One of the labs in Oyo State is actually driven through a public-private partnership agreement to increase the testing capacity of the state. Again, increasing the throughput of tests and ensuring that more tests are carried on. So all through this process, there's a lot of support that the NCDC provides to the state. Just yesterday, there was a call with the state epidemiologist with the Director General. So the health commissioner is responsible for driving the health activities in the state and reports to the governor. But below her, or working with her in her team, are state epidemiologists who are the infectious disease specialists that oversee outbreaks in the state. So there's that knowledge sharing platform as well that NCDC coordinates, and this ensures that cross-learning happens from the north to the south, east and west, and across geopolitical zones. Again, given the novelty of this virus, that's the only way we can try to move forward quickly. Again, learning from people that have made mistakes, so that and we're also doing that as a country, and that's part of the thing NCDC does, contribute our knowledge to the global discourse, but also learn from things that China have done. China seems to be managing this well. A couple of countries in the East, in Europe, seem to have gotten this well. New Zealand, for example. I know UK is not doing so great. This is not a jab. But hey, those are also lessons. You have to ask yourself, what did they do well? What did they not do well? What can we learn from those so that we can collectively respond better? So frankly, NCDC's role is multifaceted. It's interesting, it's wild, it's challenging, but we keep pushing. And that's the mantra of the agency. We keep pushing until we get this under some level of control, given that we now know to some extent that this is going to be with us for a longer time, as the Honorable Commissioner mentioned earlier.
Okay, great. Thank you for that. But we've been on lockdown, we've come out of lockdown. from NCDC's point of view, or even from state's point of view, what were some of the factors that were considered to ease lockdown and reopen the economy? Because we know while we're on lockdown, a lot of people, were suffering basically, that would go out and, have a hustle day and come back. What are some of the factors that were considered before lockdown could be eased?
Yeah, that's a very great question, because I won't call it a knee-jerk reaction, but I think it was sort of appropriate, because a lot of research has actually shown that in Africa, that's one of the things that helped the continent and not quickly peak. We're still going to peak, we're not yet at our peak. But locking down early seems to have allowed the system be able to prepare better. So quickly train more staff, have more labs set up, push out a lot of communication material, also use that period to learn a lot from other countries that seem to be getting and not getting it. So some advantage in that. But given how our economies are shaped, how the demographic is shaped, it's a bit of a huge challenge. We have, as you rightly mentioned, a lot of people who are not formally employed, who are in the informal sector, relying on getting their pay, getting their hustle from daily interaction with consumers like you and myself. So that was a bit of a challenge. And when you have, of course, the indices, unemployment rate is quite high, unfortunately, for the country. So you have a lot of people who do not have a social protection net to receive or absorb any jolt like this would have cost. So frankly, for the country, of course, knowing fully what a lot of the resources for the country are all based, that needed to be kept active. The businesses need to be kept active as well. That is for daily marketing activities, so that people can earn 1 or 2 bits of living. You agree with me that by the time the government had considered, of course, maybe with some level of certainty, like, okay, I think we're far better than where we were after the initial month of lockdown. Given where we are, what do we need to open stylishly or open systematically? And if we look through the guidelines, I think there are 2 guidelines that have been released so far to guide the reopening. The phase 2 is going to end in about 2 days. So I'm sure probably over the next few days, there might be a review or a revision of that, and we'll probably hear from the Presidential Task Force. But what happened was categorize the country into different critical segments, looking at essential and non-essential services, and thinking through who needs to work and who doesn't need to work. In the first phase, there was a curfew imposed, and a lot of course, the flights were banned, or markets were allowed to open. Again, with a lot of autonomy to the state to drive how often, the frequency of the market opening, and how long they need to open for. I think the subsequent policy guide on reopening began to advocate a lot more for use of face mask, but also layering that with a lot of protective measures, such as hand washing, ensuring social distancing, maintaining a safety distance of at least 2 meters across board. Of course, there's so many of those that were critically considered across board. So within that period, I would say we moved a little bit. Of course, given that at that phase, a lot of our cases were imported. A lot of people coming back. So, of course, the strategic decision was to enforce the lockdown, closing the airports and closing influx of more people across the borders into the country at the time. But by and large, it's been an interesting ride. Like I said earlier, we're still learning. We'll keep pushing as long as, and hopefully we get ahead of the curve quickly enough. Can you hear me?
Okay. Yes, we had an interruption there where we lost you for a few seconds, but I think you're back with us now, so that's fine. Okay. Thank you so much for answering that question. I mean, one of the problems that was around the world was the issue of PPE. And I think that's been done and dusted, it's been battered, and then we got over to testing. We do know that there's a correlation between testing and the number of cases that is declared by any country. what is the level of testing in Nigeria, and can we be so sure that testing
Can anybody hear me? I can't seem to hear any longer.
Yeah, I think we lost her there. My name is
All
Bayo,
right.
so I'll just like to continue while we wait for her to reconnect.
Oh, hi, Bayo.
Yes.
I
thank you
lost
very
a
much.
question. I think I figured she was asking a question around testing, I believe.
Okay, yes, and the correlation between testing and the, so I don't know if you got that part.
No, I just had testing and I lost her.
Oh, okay, okay. So, I mean, what I'm going to do now is to just take some of the other questions we have here while we wait for her to come back. And even
Okay.
though some of this may relate to Ogun State, I would hope you'll be able to give us some answers in that direction. So
I
there's
hope I
this
have,
question on, let's give it a trial. And if not, we just go back to the federal anyway. So just wondering what factors were considered to ease lockdown and reopen the economy in Ogun State. I mean, and I think you've talked a bit about that at the federal.
yeah, I will be able to speak more to federal because even as much as possible, when, like I said earlier, Nigeria is a federating country, meaning that you've got 3 levels of government and each level has some level degree of autonomy. Even while the federal makes a policy, it's left for the states to adopt and as well as domesticate the policy and implement as well, more like enforce those policies. So for Ogun State, I believe the parameters will still, and probably very high on the list, will be the economic consequences, as well as what the federal considered. Again, terming things that are really essential and activities that are non-essential, and looking at how best to moderate that, given how much of capacity they have within the health system to absorb the jolt. You agree with me that in addition to the lockdown, there were a lot of claims, a lot of issues that were cropping up, a lot of gender-based violence were cropping up, criminal activities were increasing, and those are things, what I probably might just term unintended consequences, but also quite relevant. So you are running away from a pandemic, but you are getting killed in your house. You're getting robbed in your house. You're getting hungry in your house. It's a very delicate balance. And I think what governments across board have done, and what I think what I will advocate for citizens to do a lot more is, as much as we'll follow the policies, but also follow the policies with the public health interventions that have been proposed. So you want to go to the market, absolutely, because that's essential. But you need to do it with wearing your mask. You need to do it with your hygiene. And personally, for me, I've been exposed multiple times to confirmed cases, multiple times. I've lost count. But the take home for me is, what did you do right? I always have my mask, whether it's a locally made mask or a medical mask that is available. At times, I have my glasses on, so maybe it serves as a barrier to anything getting into my eyes. I've got a small pocket of sanitizer I take around. If I don't have that, I quickly wash my hand in where water is available. But those are things that actually do save you, and it's the new normal. We can't. I'm sure you've heard a lot of times. That's a new normal. That's a new way of living. With airports opening right now, you have to be taking flights with mask on, washing your hands a lot more, sanitizing repeatedly, and all that. So I'm sure those are one of the those might be one, as well as other context-specific issues that the state government in Ogun considered to ease the lockdown. But you have to realize that they haven't still opened up the whole of the economy. The schools are still locked. The markets are probably not operating at on a daily basis. They is staggered. also a lot of transportation modifications in terms of volume, load, have been suggested and advocated. So, yeah, I think that will surface. I think that should surface as an answer.
Thank you very much. I mean, I think that's quite on point here. Two other questions I have here. One is, what are the efforts and what sources have we had as a country with them coming up with our own homegrown solution, localized solutions in terms of medications and then the vaccines? Then the second question would be, what role has e-health solutions played in the monitoring and managing of the outbreak? And it's okay to give us the perspective from the national, and if there's any experience you have with any of the other states, we'll be glad to share.
Well, absolutely. So first question, really about homegrown interventions. Absolutely. I mean, there's no, I think one of the key lessons, even within this chaos as we are, is how we're beginning to rethink the importance of things we have at home. Nigeria is very import focused, where we like to import a lot of things, but with a lot of disruption to global supply chains, freight is a bit of a challenge. Planes are not flying, ship probably docking, but with limited man on board. Production capacity in countries have reduced because people are not going to work in countries we're importing from. There's a lot of push for homegrown use of technology. So from manufacturing of hand sanitizers, PPEs. At some point earlier in the campaign, there was a meme going around around an Ankara-based face mask with a mask. Those are things that people have gone on to modify now, and there's a lot of variation in what we have as face shields, which are more or less produced locally, maybe with some input from international. But you agree with me, these are things that can produce locally. A lot of people are producing face masks now. You can produce a face mask in your home once you have a piece of material. So when you go to your tailor or your seamers and you have scrap materials, you actually now claim, you have a right to claim those because there's a use for those materials. Also intentionally is that it's opened up the market for the tailors right now. So you don't concentrate on wearables alone. Face masks are now wearables that you can earn some extra cash from. Again, given that you don't need to rethink or you don't need to think about how much materials you need to buy, you can quickly repurpose waste materials or old clothing that you're not using any longer. So there's a lot of push for homegrown innovations across various sectors. I mean, food delivery services now, there's a lot of bags with box at the back, delivering food from restaurants to home. So much of that is ongoing, and it will continue to evolve as we learn more about how best we can cope with this virus. So for medications, probably not much. And I think the Commissioner for Health mentioned that earlier. It's quite capital intensive. Although I know at the regional level, with Africa CDC, there's a lot of push to ensure that some of these are grown within Africa. So for Africa by Africa, and ensuring that the country is self-sufficient on its own. So there's those are in the works. Vaccines as well. I mean, quite capital intensive. Majority of the vaccines being produced currently in Europe, North America, but also within the push for within the Africa cities. There's a lot of push to ensure that vaccines are produced locally. A couple of days ago, I think last week, there's a partnership for accelerating COVID-19 testing, and a couple of other initiatives rolled out by the Africa CDC, led by South Africa president and a couple of presidents in the world. In Africa, there's a lot of that push going on now for medications and vaccinations. For e-health, absolutely. This is one disease that has accelerated innovation and has pushed for tech to be used a lot more, various components, because one, what e-health does for you at the moment is reduces the tactile layer to this. So you touch people less, you are still in charge. I mean, right, Zoom that we're using right is one aspect, and a lot of people are using Zoom to train people. The Honorable Commissioner for Health mentioned that in Ogun, there's a lot of trainings I've attended via Zoom, a lot of meetings I've attended via Zoom, where interesting decisions have been taken on this. There's a lot of infusion of that. In terms of contact tracing, absolutely. The NCDC before now had the electronic platform called SOMAS. Basically, it uses to gather, analyze, collate data on outbreaks. Within this outbreak, that has been expanded immensely to be able to incorporate other modules on case management, laboratory case notification identification. So there's a lot of infusion of that. A couple of weeks ago as well, on the NCDC website, microsite, there has been an add-in for official add-in for for a self-assessment. So you can quickly go there and just go through a couple of questions and tell yourself if you're at risk or not. A lot of other private individuals are also doing a lot of interesting work. So a lot of apps going out there, Bluetooth based, that can be used to support contact tracing, but also the phones that we have are being enabled to be able to communicate seamlessly a lot more. Again, over the last few weeks, I think Apple rolled out an update to their to the phone to enable ease of communication on the phone. I think Google is also doing that. Google, on its own, has also leveraged the data they currently have to inform or to show the changes that occurred with mobility. So there's a global mobility database or global mobility data on how movements changed across different time period. For Nigeria, it was quite interesting because we actually saw a decrease in the movement of people into offices, to supermarkets, to offices, and a lot of more increase in people staying at home across the country, basically. So data is publicly available and something people can access. So there's a lot of infusion of that, and it will still continue because across different areas: finance, food, health, EMR, teleconferencing, telemedicine, and we'll keep moving on from that. I think frankly, we are in a new world, quickly accelerated new world, and things will keep unfolding as we go.
Okay, thank you for that, Dr. K. Another question I have for you is that Dr. Coker mentioned we haven't peaked. You also mentioned we haven't peaked. When are we going to peak, or how are we trending? Because I know it relates to the R rate, and I know I mentioned testing earlier on. How does all of that come together? Should we be scared that we will peak? Because we know that in some states, there are more cases than others. So we also have a migration issue. So what I'd like to know from you is that, what are some of the measures we're taking to discourage migration? And when are we going to peak, and what are we doing to ensure we do not peak, if that is an option?
Great. So measures to discourage. So I'll start with the measures to discourage migration. Before I say that, I would like to mention that I think Dr. Coker mentioned that as well. The disease doesn't move. The virus doesn't move. People move the virus, which is why it's important to try to enforce the lockdown or to propose a policy to enforce the lockdown. But like I've mentioned repeatedly, Nigeria is a federating structure, so they have a lot of 36 autonomous states and 774 local governments. Enforcement of policies is situated within states. So even if the federal proposes a policy, the states are in charge of ensuring those policies are enforced. There's been a caveat to who needs to move and what needs to happen for essential service, for agricultural materials to move, for a couple of others essential vehicles to move around. But you see, citizens will always be citizens, and a lot of those are being, unfortunately, not strictly adhered to, and that's one of the challenges with this so far. So you propose policy, but then the enforcement is on that angle. As far back as last month, the governor of New York, for example, was joking about that because they had the same challenge. So it's not the same. So you have 18, 20 or more million people in New York, and you probably a lot more. You want to enforce the lockdown. Does that mean you arrest all of them and put them in prison? Where do you keep them? You don't have the resources. So you need to. So that informs a re-strategization. You need to re-strategize to think through how best to communicate to people. And for that, NCDC, what NCDC is, it was propagate the take responsibility slogan. meaning that as individuals, you need to take responsibility. And in taking responsibility, it includes adherence to policies that are put out by the federal government, but also personally within yourself, what do you need to do? There's a lot of talk about the 3 W's. Wear a mask consistently, especially when you're going outdoors, we're going to crowded places. Wash your hands regularly and watch your distance. Make sure you ensure you have a 2-meter distance between people. So that is pushed consistently to ensure that people take responsibility. To reach out to people a lot more. A lot of engagement of Hollywood and Nollywood actresses to push information through social media platforms, through Instagram, Twitter, but also knowing fully well that spans to a section of the public who are literate and have mobile phones. They can access Twitter. There's a lot of movement towards the community, engaging traditional rulers, engaging the existing, Nigeria has been a potpourri of events such that we can easily and quickly leverage resources. And now polio is one. Last 2 weeks, Nigeria just got certified to be polio free, and a lot of those resources that were used to rid the country of polio are now being leveraged for this. So a lot of the community-based institutions, so the religious leaders, the traditional leaders in the north and the south, passing those key take responsibility information to the grassroots, because you can speak all the English. If the person in your village, in my village, doesn't understand what it means to cover their nose in their dialect, you are basically just speaking English. And those are the people that are more vulnerable. They are older. They are more at risk, given what we know about the epidemiology of the disease so far. They may have comorbidities, and they may be quite helpless because a couple of their kids have traveled in the cities. So we need to quickly get those information to them, and that's a lot of the push in that regard so far. I think your other question was around. Sorry, if you remind me.
The peak.
Yes, the peak. Absolutely, yeah. So, given where we're seeing, we haven't picked the modeling estimates, and we have to be very cautious with modeling. It helps policy decision. It augments, because you need to wear human cap to interpret what you're seeing from modeling estimates. You don't go head on and take model. But given what we know, given our positivity rate, given the number of tests we're doing per day, given that we are still seeing a lot of cluster of cases on a daily basis, we're yet to peak. Estimates actually suggest that we might peak as a country in August. As of yesterday, there was an output that actually mentioned that we might be peaking in August. Of course, different states will be at different phases, and this will also be driven by what each state does, within the response. So you have a couple of states on top of the game, and others that are still largely laggards. And again, I'll make reference to New York. Just this morning, there was a disaggregation of the data between what's happening in the Northeast, where you have New York, where a lot of the outbreak was in early May to late May. Now it's been brought under control, but you are beginning to see huge clusters in the South and in the West, in the US, and that spike is on the way up, compared to what you're seeing in New York that's going down. That's given what that region did to quickly mop up the virus, and we'll keep seeing this variation across board. So peaking will depend on what each state does, but also very importantly, you have to understand that the country is made up of people. What people do will reflect or impact on what happens in the country. So you need to ensure you wear your mask. If you don't need to go out, just stay indoors. It's not absolutely required. Like I said earlier, the virus does not move people, move the virus. So the lower we move, of course, mathematical jargons is the R0. R0 is basically the rate at which these illness can be propagated. So if you have once it's greater than 1, once the R0 value is greater than 1, means the illness has a propensity to be transmitted to someone else. So as much as possible, everything we are doing, the wearing masks, is make sure that your R is less than 0, such that you cannot transmit or propagate the infection. And that's a very key parameter that epidemiologists look at of what drives the infection. So we need to collectively take responsibility and ensure that by the time we aggregate all our efforts, it tracks up to a holistic response that can help us flatten the curve eventually and also keep it at a reasonable rate and not overwhelm our health system so much, because it's quite weak. We have to say that. I have to say that.
Yeah, absolutely. And we would have thought that a lot of health organizations will crop up from this experience, but I guess that's another topic for another day. There are a couple of questions that are coming through. One of the questions is, we've noticed that in the midst of COVID-19 pandemic, we've seen prices of drugs used to boost self-immunity against the virus going up. The question is, what is the federal government doing to avert this?
I'm not too sure I'm in a position to speak on that. I mean, there's a federal government agency responsible for that, NAFDAC. I don't work with NAFDAC, but I mean, my opinion is that that's bad practice. It doesn't show patriotism. It's price gouging. It's not encouraged. We don't love ourselves, really, and it's just quite unfortunate that that's the situation with things.
Okay, all right. So we also have, I mean, you talk about the collective responsibility and how it's been communicated to every level of education in Nigeria. So obviously we're using the social media, we're using the TVs, we're using the radios, etc. In terms of looking at the quality of what we use, you mentioned earlier on as well, you said people are making masks. How can we be sure that people are using masks in a safe way, for example, and that we're not being exposed to people that want to make a lot of money from remedies that might actually hurt people? Is there any sort of guideline in the NCDC? I mean, when you go on YouTube, they tell you how to make a mask, for example. So, but, you know, how do I tell somebody in the village how to do that? You know, enforcement is an issue, but strict and strong and well-tailored guidelines will help people. What sort of part is NDC playing? And I guess they'll probably work with NAFDAC in terms of that as well. I'm not sure. But what part are they playing when it comes to safety of these measures? You know, even with the quality of water you're washing your hand with.
So that very good question, and the answer to that is yes. There's a guidance by the NCDC on how to make mask, DIY mask in your home, and a lot of things that the NCDC has also encourages. You can take these materials and run with it. So if you, if a couple of other things I've done, I've worked with a couple of colleagues, is to propagate some of these communication materials. So I speak Yoruba. The NCDC has published guidance in, or they're yet, or they, I mean, given, or you're having different feeling of what you're hearing on social media. You're like, oh, what do we need to put out? You quickly develop such materials and you push those out in various dialects, you know, and blast through your channels. But for the mask, absolutely, those guidelines exist. And a lot of people are using that to, I think they're using that to develop the mask, probably churning out. But also, it's quite difficult to monitor what I do in how I produce my mask. You know, it's not, there's no I don't think there's any requirement per se. There's a guidance that stipulates what you need to do to make the quality of mask that is required to protect yourself. But the quality assurance of that, I don't think is available at the moment. You have to understand how the markets work around. There's a lot of informal trade. A lot of people that sell the mask actually sell it off the street and on the road. So you're in this little traffic, someone comes to your windscreen and you're able to pick up one or two masks. Again, understanding that they need to earn a living, they need to quickly find a way to make business, get some change. So, except you are making the mask yourself, then you are guaranteed of the quality of the mask you're making, which is why it is a DIY, do-it-yourself guide of what needs to be done. So I would recommend that versus picking up, except you have one that is picked up that has all those fine print written. oh, this is certified by X, certified by Y, and this is this and this is that, you know. So, but however, I think it's better than none, and we have to be clear about that. At least for yourself, even though you might be infected and you don't know you're unknowingly transmitting, people will call it asymptomatic, although there's been a bit of discussion on that. You have to cover your respiratory pathway, so meaning your mouth and your nose, just to make sure that one, for people around you, they're protected, but also people within us. You know? So I think that's the response to that.
Yeah. Okay, great. Thank you very much for that. I think we touched on testing earlier on, but the question here is that, are we testing everyone, or is it just those that are symptomatic? Is everyone who presents themselves to the hospital tested?
So testing is been quite tricky, and I will start from one, having the infrastructure to test. This was not enough, and this is not oh, Nigeria, why didn't you do this? Absolutely, maybe to some extent, but with this disease, given the peculiarities of the special equipment you require, this was not ubiquitous. Like I mentioned, there's a quick ramp up from number of laboratories that have the capacity from 5 to 39 as of 2 to 3 days ago. Given that, not every center will be able to test. Also, given the challenge with that, I think the Commissioner for Health mentioned that there's a lot of decentralization going on. Part of the decentralization is increasing the number of testing sites and ensuring that more samples are taken from personnel. And again, as much as possible, this is within the purview of states to implement. So what states need to do to get on top of this? Again, you have to understand that what the NCDC does is support and provide technical assistance. Like I said, the states are in charge and driving the response. I think the Honorable Commissioner of Health gave a beautiful description of how that works in Ogun, and that's the proof of what's expected across a couple of the other states. So for the testing, the states are in charge of that, and they're making a lot of efforts to ensure that is quickly ramped up. Given the challenge with infrastructure, given the challenge with supplies and reagents, you have to know that everybody in the world is queuing up for the same thing. You know, that's a huge challenge. Even though you get it, how do you get it in country? Because a lot of flights are freight is also probably limited, because only a handful of companies offer freight services, because of not everybody moves cargo, but then that also comes with at a price. So a lot of challenges with that. So, and that has affected how many people can get tested. What has happened over the last few weeks is the easing of what we call the case definition. Initially, it was very, very strict, given what we knew at the time. And I think it's gone through different versions. But at the moment, there's a lot of push for use of community case definition, which is defining how people get tested. So where you get tested and how you get tested is very state specific, and a lot of communication call center lines that you can call or reach out to your state to find out where to get tested. This will change across different states based on the capacities they have and how they are quickly able to deploy and push people on the field to get testing done. So it's what operates in the FCT, Abuja might be different from what happens in Abuja, might be different from what happens in Kano, what happens in Cross River, or what happens in Ebonyi, give or take. But so it may be a bit difficult for me to state specifically how the states get around that. I can talk about the framework, but how it's done, it's very state dependent and state specific. But what the NCDC has done and what she has provided is the guidelines for testing and what needs to be done, and as much as we're providing some of the resources and reagents to make sure that tests are quickly carried out and requisite contact tracing activities are done.
Thank you so much, Dr. K. Thank you. We really appreciate the time you're spending with us this afternoon. Thank you so much. There's another question here. Are there currently gaps or voids that still exist from your experience that can be resolved by a novel e-health solution? Have we seen it all, or is there still room for more innovation?
There will always room for innovation. There will always room for innovation, but then it's a push-pull, right? It depends on what angle you're looking at it from. So even your understanding of the system will help you channel what type of intervention or innovation that you need to roll out or you want to propose. And you need to keep looking for even technologies that have institutions that have been running for years. There's still ways to disrupt the system. So, but you need to keep looking. Of course, there are gaps, I believe, maybe not appropriate to be spoken with on this platform, but absolutely, if you keep looking, the data points to some of those. And for someone who's interested in innovation, those are quick guidelines that you can look at. Data almost never lies. You look at it, you tell a story, and you can use that to influence what innovative idea you want to propose or work on.
Yeah, and I'm glad you mentioned data actually, because Nigeria has always been one of the places where we may not have reliable data. We had a statistician in one of our series the other day who was covering some of the data that is being collected by Nigeria. With regards to the relevant data for the pandemic, can we rely on the data that we see from day to day? And I think this also links with the level of testing that is available in a decentralized manner. How reliable is the data that is coming out? And what does NCDC do in terms of that? What role are they playing?
I believe the data coming out is very reliable, given how it is collected is electronic, and it's so I mentioned earlier the platform, the SOMAS platform that the NCDC uses and this connects the teams from the surveillance or people working on the field to the labs, because the results are not sent paper based. Maybe they are issued paper based when the client receives the result, but they're all electronic, and every patient, every client whose sample is taken on the field has a unique identifier that tags that person uniquely and by state, and that works around different laboratories that is seen nationally. It's a bit around how you're collating results electronically for elections. Only that you can't rig this, at the moment. Yeah.
Okay.
So that system exists, and that's helping easy collation and the analysis of this result. And I think Dr. Honorable Commissioner for Finance, Asuko, just joined.
He's here. Mm-hmm.
Yeah.
Yes, he has, and thank you for announcing his arrival. Thank you so much, Dr. K. I'm going to come back to you, so don't leave us yet. Honorable Minister Ekpeyong is here to join us. Thank you so much, sir. We know that you're kind of in transit, but you've taken time to be with us this afternoon. We really do appreciate it. Thank you so much. Please permit me to just give a brief introduction to our audience about who you are and what you're going to be covering with us today. As I've addressed you earlier on, you are the Commissioner for Finance, but also the Secretary to the COVID-19 response team in Cross River. So your background is economics from University of Reading, where you got an undergrad and a post-grad qualification. You're a member of CIB, so you're a true finance man, thick and thin. And you've also been a lecturer as well in University of Calabar, and you've worked as a commissioner for transport and marine services. What we really would like you to cover with us, if you may, sir, is perhaps talk to us about the Cross River experience. We hear that Cross River does not have any cases of COVID-19. And I think our audience would want to know how that is, why that is, what are some of the things that you have done to ensure that. So, sir, I would like to invite you to address us, and would also encourage our audience to give you a warm Zoom welcome. Thank you so much. Over to you, Honorable Commissioner.
Good evening, madam. Thank you very much. I apologize for joining in late. I just landed. I've been in transit and I've just landed. And please, you'll forgive. My daughter is in the background. We're in the car, and so she's. They came to pick me up. I'm traveling for work, and just since I'm in the city where they are there, I took the opportunity to just hang out with them. So it may be a bit awkward because she's a toddler, just a year old. All right, let me not take too much of your time. In Cross River State, our response has been in all fronts of the prevention, treatment, and control of the novel COVID-19 pandemic. Our leverage on prevention started with the activation of Emergency Operations Center, sensitization in both rural and urban areas, border towns, and we instituted movement restrictions and carried out surveillance of wide expanse of the population. We focused on a lot of suspected case tracing, etc. We were the first state in Nigeria, and actually one of the first governor. The governor of the state, Sir Benedict Ayade, is a professor of science and a scientist. He early on started. Let me start by saying this: if I was asked to, in a single word, to describe Cross State's management of this pandemic, it would be proactive. If I could use a single word to describe it, we're very proactive. The state governor, Benedict Ayade, he studied the rate of transmission across China and Southeast Asia, and was left with no doubt that the virus was going to make landfall across Europe, America, and eventually Nigeria. And so we proactively started planning and implementing as early as January of this year. The governor of Cross River proactively started screening persons coming into the state as early as January. We created holding bays at Margaret Ekpo International Airport, working with the health port officials. We screened at motor parks, seaports, airports, interstate borders, and major roads. The state further went on to purchase $100 vehicles, and we set up the cover any case was even registered in Nigeria. I was appointed as the secretary because, as you very well know, this pandemic is not just a public health emergency; it's also an economic emergency. We're going to have to think outside the box and create a lot of stimuli for the local economy to bounce back from the recession which we have found ourselves in. So beyond the purchase of vehicles and setting up of the task force, we deployed these vehicles and teams to the various border points across the state, as well as across Calabar Metropolis. The governor himself led from the front. He kept vigil at some of the entry points, the major entry points into the state. And when I say keep vigil, I mean there were times where we spent the night at the borders to ensure that we did what we termed a lockout. It wasn't even a lockdown because we knew at first we had no case because we started early, and so we locked out Cross River State from the rest of the country. Now, Cross River State is very unique geographically. It borders with Benue, Abia, Ebonyi, Akwa Ibom, and of course Cameroon to the right. And the ocean to the south. Be extremely vigilant. We started sensitization of the public, jingles in all the dialects in Cross River, TV shows, radio shows, press releases, and IC materials. We put up billboards and posters in border towns and in villages. We used town criers. We collaborated with the Christian Association of Nigeria, Muslim groups, traditional rulers, and ward development committees to take the information to the grassroots. So Cross River State has an extremely high level of sensitization in terms of the virus. We get calls from the villages.
Okay, so I think
we are informed and sorry?
Yeah, go ahead, please. Sorry.
Okay, we're informed that we set up toll-free numbers, and members of the public can call in, inform the response team, and immediately the state epidemiologist sends out a team to take samples for new entrants into the state. In the area of legislation, the Cross River State government partnered with the House of Assembly to pass a bill for public health safety during pandemics and outbreaks, which was signed into law by the governor. The law stipulates very hard sanctions for persons who violate public health guidelines in the state. Enforcement has received a boost from the judiciary, who provided mobile courts across the state where offenders can be tried on the go. In the area of, like I mentioned, we didn't institute a lockdown, but we instituted a lockout. Now, obviously, that slowed down the economy of the state. The free movement of goods and services were stalled, and that came with the attendant adverse economic effects. Now, as we know, Nigeria is a country where there is a large proportion of our population that are on the lower quartile or percentile, and they depend on daily income. And so we had to create welfare and sustainable palliatives, palliatives in order to protect, not just protect lives, but to protect the livelihoods of our citizens. We provided foodstuffs and other commodities. To vulnerable groups like physically challenged, etc. The government also approved the employment of 8,000 workers within the health sector. 8,000 workers, while wherein the health sector received 1,000 surveillance officers, 600 nurses, and 400 doctors. So 2,000 of the 8,000 jobs were assigned simply to the health sector. The idea was to engage people in the areas of surveillance officers in the rural across the 18 local governments who report back to the state's team. We thought that this would be a method of governments expending more and thereby generating more employment and allowing some income to pass through the economy. So at this point, I think other response activities that the task force instituted were, like I said, the no mask, no movement, the use of face mask while in public, physical distancing, bans on crowded activities such as churches, mosques, markets, and sports creation hubs, entertainment places, etc. I can go into further details about our case management or epidemiology/surveillance, if you will, if that is required, or if you want us to interact.
Okay, no, I mean, we'd love to have questions, so please keep your questions coming, audience. Thank you so much for that coverage. That is amazing work. We had Ogun State earlier on. I think it must be a competition between the two of you, but I love the idea of the lockout. You know, I think that is a very, very proactive measure and tells us why you have been successful in not getting cases in Cross River. I mean, one of the questions that we have coming up as well is, I mean, from me actually, my question is, when you started the early screening, when no one knew what was going on, when no one knew that it was eventually going to hit Nigeria, what was the reaction of Cross Rivers to that? You know, when by then it wasn't declared a pandemic. So did people not wonder why you're screening them? Did people not wonder why you had a lockout? What was the reaction to that?
Well, like in most things that people don't understand, we were vilified. The general public, first of all, thought we overreacting. I remember getting a call from the U.S. Embassy, the U.S. Deputy Embassy over in Lagos, and the head of I think it was the political or economic desk, called and said that they had heard rumors that there was a coronavirus in Calabar. This was in February, and I said no. And then she was like, well, there's been reports of extreme measures being instituted, etc. And I said, well, we're just trying to be proactive. We're trying to make sure because the thing is, right, when you look around, you understand the country we live in. And we began to witness, China and some parts of Europe getting under this, having transmissions and a lot of cases, and the health sector being overwhelmed. And we realized that if the pandemic, or well, at that point in time, it wasn't a pandemic, but if the virus was to reach Nigeria and transmission being as easy as it was being stated at the time, we knew that our health sector would not be able to manage such a crisis. We were ill-equipped and ill-prepared to manage this sort of pandemic. And so we started by saying, you know what, prevention is better than cure. Let's hold out as long as we can. Let's try and put in measures and plans in place to ensure that we can hold out as long as possible until a vaccine or a clinical treatment is established for this. Because at the point in time when we're talking like late January, February, all this was very novel. It was there was no clear-cut medical treatment for the disease, and so we focused on prevention. That was it. And like I said, we didn't get a lot of assistance from the general public. People thought that we were being excessive, and what we now had to do was to engage constructively with civil societies, NGOs, with the general public, explain to them what we're trying to do. And I'll be honest with you, most of the challenge I feel that most governments, especially subnational governments, have is lack of communication. What they do is inform. That's just one way. They just tell people, but they don't engage the people, so they don't hear back from the people. The people don't get to interact and ask questions, and then the government answers. Because when you do that, you find that people, you start getting buy-in, and once you get buy-in, that's everything. That's it. But once the people partner with government and say they understand and they get the reason why, but once we had that, it was all downhill from there.
Yeah, absolutely. Oh, fantastic. Well done. The question I'm going to ask you as the Honorable Commissioner of Finance as well, I guess your role is to make sure that you spend wisely. And in a pandemic of this nature, how easy is it for you to make that decision when sponsoring health policies or measures? How has that kind of impacted your day job? So on one side, you are the secretary for the response team, and then on another side, you're the custodian of finance for the state. How would you say that has worked out for you, and how have you been able to manage your two roles, considering there's a possible clash?
Hello?
Yeah, did you get that
Hello,
question?
can you hear me?
Yes, I can. We can still hear you. It's cutting out on my end, but we can hear you.
Hello?
Yes, we can hear you now. Did you get the last question that I asked?
Hello?
Yes, we can hear you. Did you get the last question I asked? You're muted. Okay. There was a question for you, Dr. K. There's a note in there, and I think somebody's challenging the decision of NAFDAC or your interaction with NAFDAC. So perhaps you want to have a look at that. But there was a question as well that I needed to ask you, and the question is, what is the country doing on doctor-to-patient relationships considering the situation we're in now?
Is it the doctor-to-patient relationship?
Yes.
Okay, so considering the situation we're in now, if I get that question, doctor-to-patient relationship, okay, so of course, the downside of this outbreak is that a couple of essential services have not been functioning optimally. A lot of hospitals are not readily taking running clinics, for example, and basically concentrating services in the emergency section, such that that limits exposure to patients who routinely come to clinics, who at times are often busy. And you have, if you've been following the trend in the news as well, you understand that people who have existing comorbidities are more at risk of dying, for example. So if you are clustering such in clinics and one or two persons happen to have COVID, you're setting yourself up for a huge cluster of an outbreak within the pandemic. So what has happened is systematic scale down of services across hospitals, which is a bit not so great, which is why on the public health side, there's been a lot of push to ensure that some of these essential services keep working. But what we're also seeing a lot more is that given the position where our medical personnel are, we're having a lot of healthcare associated infections with doctors, nurses, and a couple of other healthcare workers coming down with the illness. Some have succumbed, unfortunately. This is the same trend across the world. So Nigeria is not in this bucket alone. But it's really sad, but of course it basically emphasizes the importance of IPC, infection prevention and control strategies, and adherence to use of PPEs a lot more across health facilities. Unfortunately, in Nigeria, I think there was a bit of a strike, a couple of days, which has been called off again. Some ongoing issues between the Association of Resident Doctors and the federal government, which may have had some unwanted event. But hey, I think for Nigeria as a country, we always find a way to pull through. You know, this is an interesting trait, but I think that's where we are. I hope that answers what you wanted to hear about relationship between doctors and COVID, because that's the angle at which how I understood it, and I hope I've provided some context.
Okay, I'm sure the person will come back to us if they're not satisfied. I'm not sure if you got a question, but perhaps something for you to think about. NAFDAC mandate do among safety, quality, and effectiveness of regulated products. Pricing of drug is not a mandate for the agency. In this person's opinion, that the federal government, NDC, are to set up a committee relevant and with relevant stakeholders, hiking of preventive drugs are averted. So this is going back to the point of how are you making sure that people are not hiking up their price. I think the recommendation is here for you to take it back to NCDC to see what kind of role can be played. I really don't want you to go into too much detail. I think it's just one to ponder on. And as you said earlier on, it's going to be quite difficult for you to defend that position right here now. So perhaps it can be something to take away and suggest, you know, from our discussions. Okay, thank you so much. You've been an absolute star. We are so lucky to have you. The only thing I'm going to say to you is that if you were to advise us as we part as individuals in less than 10 words, what do we do individually with COVID-19? In less than 10 words, and your closing remarks.
Take responsibility.
Brilliant. Thank you very much. So, audience, we have been so blessed today to have so many people speak to us from the state that had the index case and the measures that they took and where they are today, the provisions they started with. That was shared with us in Ogun State by Dr. Tomi Coker, who is the Honorable Minister of Health. Also, we had Dr. Kayode, who has addressed us for the entire period and taken your questions from the point of view of NCDC. And he speaks as an independent consultant who has been working closely with NCDC. And we've had a lot of advice from him as well. I particularly like the 3 W's, and I think if anything we take away today is to remember to wear our protection, wash our hands, and watch our distance. I think that's very, very easy to remember. He's also advised us about getting education, using our social media proactively and responsibly to share the good news and preventive measures and good practices. And most of all, I think the most important advice he's given us today as well is to take personal and collective responsibility, because we cannot leave it to the state, we cannot leave it to federal. We all have a part to play, and we must continue to push the virus out, because it is people that move the virus around. And of course, we were so lucky, even if it's for a short period, to have Mr. Ekpeyong, who is the Honorable Commissioner for Finance in Cross River. And unfortunately, we kind of lost him in the call, but I think he shared some really valuable points with us. And when he talks about a lockout, it was about Cross River getting there before everyone. So they were very, very proactive. And he's giving us reasons why they've never had a case. We would have loved to ask him a few more questions, because I'm sure people still doubt it's absolutely impossible for Cross River not to have a case. But unfortunately, he's not here at the moment. But if you do have any questions for him, we encourage you to please put it in the chat box, and we promise to get back to you via email with a response to your question, even though he's not here because he's in transit. It leaves me to say thank you to every one of you that have joined us today. We appreciate your presence. We appreciate your engagement, your contribution, which is invaluable. And there is no way we can hold this without all of you dialing in. So thank you so much to every one of you. Would also like to thank our panelist, Dr. Kayode. Thank you so much. You've been an absolute star of the show. Absolutely brilliant. I love the cap, by the way. I meant to say it at the beginning. You have risen to every question that we had today, and we really appreciate your wealth of knowledge that you've been able to share with us. Thank you so much. We reserve the right to call you back as a specialist by all means. And of course, we thank the two commissioners that joined us, Honorable Commissioner Dr. Tomi Kulka from Ogun State and Honorable Commissioner Mr. Ekpeyong, who we had from Cross River. So thank you so much, everyone. We hope to see you at the next series held by Periscope in our pursuit to keep spreading the good word, the good practices, and with the hope that we eventually eradicate this horrible pandemic known as COVID-19. So thank you so much once again. Have a wonderful evening, every one of you, and we hope to see you at the next series. Thank you and good night.
Good night.